opportunities to learn about resources, information on practices and opportunities for learning that are out there that you can take advantage of so that you can support your students with the most updated information possible, and to give you more opportunities to connect, because sometimes we do feel a little bit alone out there, but we always try to work within the framework of quality improvement, leadership, public and community health, and then care coordination. So just as a reminder, make sure you keep your mics muted. If you have any questions, please raise your hand or put something in the chat. Both Sheila and I, and Kathy, when she's available when she's not presenting, we're keeping an eye on the chat so we can make sure that we get your questions answered as well. Also, we do have clock hours available, and I'll go into that a little bit more at the very end. So I did want to take a moment to thank all of our attendees from our health districts. Thank you for being with us, and we really appreciate all that you do to support us, and we're glad you could join us for this as well. So I thought I saw Ryan join us here in the last few minutes. Ryan, are you on our meeting? Have you joined yet? Okay. Well, how about we give him a few more minutes to join, but perhaps we can jump right in with our school nurse updates. Kathy, would you mind giving us even just a little taste of what you've got for us while we wait for Ryan?
Sure, I can pull up my presentation and we can just start off with that. You just go out here. Are you able to see my slides now?
We can see them. They're not in the slideshow mode, but we can.
Right, but you can see my screen. Okay, well, let's go ahead and just go through an update here this morning. And then if Ryan is able to join us, maybe we could just switch places. Okay, so I just want to start out this morning by, I think it's wonderful that we all had a 3-day weekend and had a little opportunity to step back, hopefully, and take a deep breath as we move into this week. But one of the things that I always like to start out with is just an opportunity for you to give some thought to things about your job that are very satisfying to you, that bring you joy from day to day as you work through. I know there's a lot of struggles at times. There's a lot of stress involved in the work. And sometimes things are sad as well. And there's bad situations that I think people are getting involved with at school, trying to help the students. But this is just an opportunity to think about what you love about your jobs. And I'd really like you to just take a minute and think about what it is about your job as a school nurse that you are passionate about and that actually does bring you joy and satisfaction on a day-to-day basis. And just give it a minute, think about it, and go ahead and type something into the chat. Just a word or two is great. And we'd love to hear what it is about your job that makes you happy. So isn't that wonderful? Look at all these comments coming in about working with students. It's really true. Everybody loves to work with students, and I hope you get the opportunity to do that. I know sometimes often it feels like you get pulled in so many directions that you don't actually get as much time as you would like to spend with the students, but I know how much joy just that interaction with students can bring you. So thank you for sharing those comments today. I do think it's really important for us to always at least step back and think about what it is about our day-to-day work that actually brings us pleasure. And I hope, and my hope for you is that you get an opportunity to spend time doing that this week and really getting that pleasure back out of your job. So let's do some. Ryan is on. Well, what would you like me to do, Lena?
If you know, if you wouldn't mind putting a pause on the updates, let's go ahead and let Ryan present his information, and then because this is a good spot to before we dive into the ESG updates.
Okay.
That works for you.
Oh, yes.
Okay, great. Um, so Ryan, hi, I can see you.
Hello.
You do have the ability to share your screen.
I hope
If
so.
you have your updates, if you have your slide presentation.
I hope so.
Great. We're glad you could join us this morning. Thank you so much.
Yeah.
So everyone, I would like to introduce you to Ryan Schaefer from the Providence Spokane Hospital, the electrophysiology specialist and coordinator of Project Atom in our state. And Ryan, are you able to share your screen so we can see your, there we go. Perfect. Awesome. Thank you so much.
Sorry, I don't do these websites very often. Most of the stuff is in person. So if I'm a little clunky, I apologize. Um, well, thanks for having me this morning. I had you down at 9:30, and so I was running across the campus to get here at 9. So I apologize for being on late. Anyway, my name is Ryan Schaefer. I'm the clinical nurse specialist for the electrophysiology program here at Providence, and I'm also the Project Atom coordinator for the state of Washington. So Lena had asked me just to share some of our information about Project Atom. So thank you for having me. Hopefully this will be a in-depth conversation with you guys. Some of you, this is a little different than the OSPI. I presented at the OSPI grant, I don't know, a couple months ago. So there's some overlapping information, but it's a little different. It's more of a deep dive into this. We had originally talked about just doing some minimal stuff, and then one of your presenters was gone, so I extended it a little bit. So hopefully that's okay. So today's objective really is to talk about the problem of cardiac arrest out there in the United States in our community, introduce what Project Atom really is, identify some sources for your schools, and identify best practice around AED implementation. I think the takeaway really is to have all the schools in ESD 171 meet some minimal standards about having AEDs on their campuses. We'd like to introduce and how to become a heart-safe school, but the main takeaway really is to develop a partnership and alliance with ESD 171 and all the school districts. So I think it's reasonable to start with the magnitude of cardiac arrest out there. It's really not an uncommon thing. It happens to about 1 in 1,000 adults a year. Cardiac arrest takes more lives than all other disease states out there in combination, I guess. It's somewhere in the range of 350 to 400,000 individuals a year die of cardiac arrest, which is more than lung cancer, stroke, breast cancer, and AIDS combined. It's interesting that cardiac arrest really doesn't get the attention across the United States as some of these other disease sources. Stroke and breast cancer have pink outs, and Go Red for women signifies women's heart health, but cardiac arrest doesn't really have a national emblem or symbol out there. It has a few weeks that they identify and bring awareness, but nothing really has got a lot of traction out there. So what about in the younger population? It really doesn't have any age limits, and it succumbs younger ages as well. There is no mandatory reporting agent out there or registry about children and adolescents. So the true numbers are really hard to define, but we know it's less common than adults. It affects some of the um, older studies said it was about 1 in 100,000 to 200,000 students or young people a year. But the more recent studies really show about 4 or 5 individuals per 100,000 or 100,000 individuals a year die of cardiac arrest. And so that's about comes out to about 7,000 adolescents a year. There's lots of different causes. Most of them are the kids are born with. But we know that it's the cardiac arrest or is the leading cause of death among young exercising athletes. And this is despite all the preventative things going on out there, the pre-participation questionnaires, routine physicals and screenings. EKG screenings has made some traction across the state in the United States. And then we have these robust EMS systems out there with our average response time somewhere in the 4 minute to 8 minute time, but yet we still are having these young adults unsuccessful. So really the ideal heart safe prevention program really doesn't exist out there. It's still a debate, but these kids are not being successfully resuscitated as they should. And really, most of it is because some of the treatment is delayed, and those are all reasons that are overcome. Most of individuals are unaware of what cardiac arrest really is, and that it happens to young adults or can happen to young adults. The overall incidence is relatively rare and low as you look across. I wouldn't say it's rare, but it's low. It doesn't happen on a daily issue, especially in certain communities. I think the big thing is that rescuers or lay rescuers are oftentimes inaccurate at trying to assess a pulse. They mistake gasping breathing or agonal breathing and seizure-like activity for looking like a seizure. So it's not common to say that they're having cardiac arrest. But I think the other thing is it's just so surprising when a young adult or a young athlete drops over from cardiac arrest because they are considered some of our healthiest members of the society. And then the last thing being is that the majority of the nation or schools lack the comprehensive secondary prevention programs where they place AEDs and develop best practices surrounding it. So when you look at the incident of cause cardiac arrest across the nation, what really happens on these school campuses? Here's a study out of Seattle that John Dresner did, looked at about 2,100 schools, 2,000 schools over a course of 2 years. And of those 2,000 schools, there ended up being about 59 cardiac arrests on those school campuses over 2 years. And that came out to be about 2 in 50 schools would have a cardiac emergency every year on their campus. 2 out of 70 would have a full-blown cardiac arrest. And when you looked at the numbers, it had more adults on campuses versus the students. And of the students, there were more student athletes than non-student athletes. And you look at the sheer numbers on campuses across the United States, there's about 63.5 million students, faculty, and visitors on a school campus every day in the United States, which is about 20% of the US population. And you go back to those original numbers of 1 in 1,000 and 1 in 100 or 4 and 5 to 100,000, it just makes sense with the numbers that some of these individuals are going to harbor these unknown issues, cardiovascular issues, and we should be prepared. Now, if that doesn't give you some pause, here are a list of some of the young adults and adult cardiac arrest on campuses across the Spokane region and throughout the Northwest that I know about that ended up at Sacred Heart Medical Center after their arrest. And it comes out to about, I think there's 19 of them there. Now, I haven't captured all of them, but those are just the ones I know about and been involved with over a course of about a decade. So that's about 1.5 per year over the course of 10 to 12 years. So Project Adam was really founded and originated after the tragic death of a 16-year-old student athlete in Wisconsin. He suffered cardiac arrest while playing basketball. Um, and he ended up having what was called hypertrophic cardiomyopathy. His family and friends and the cardiologist involved started Project Adam, which means automated defibrillators in Adam memory. And it was started around 1998, 1999. Not only just for Adam, but there was a rash of young adults that had cardiac arrest in that area. And so the family and the friends and the cardiologist figured they needed to do something. So they did start Project Adam. And subsequently, Adam's death on that basketball court, you hear these stories of everything going wrong, and that was his demise. There was an AED in the school. The identification got delayed. The EMS was delayed in their response, and subsequently he died at the hospital later. So Project Adam now is really a national program that started back in Wisconsin. We joined Project Adam in about 2010. We were the 5th affiliate across the country, and now it's been throughout 33 states with 45 different programs. These are all backed by children's hospitals and funded by children's hospitals and are housed within the children's hospitals in that area. Our goals really are kind of simple. We stay school focused, although we do get into youth sports and some essentially, if someone calls us, we help them, but we're really school focused. We hope to create awareness and signs and symptoms of cardiac arrest and the need for AEDs on campuses. We want to develop and help schools have a process for implementing public access defibrillation programs. We want to be a resource for schools and site coordinators, also a community resource with the medical expertise, know what the state laws are. We do some research across the country. One of our biggest things is really our hope is to create a multiplier with schools. So if we can teach a school and individuals within that school about AEDs and the signs and symptoms of cardiac arrest, and then and CPR, and then those individuals are on school campuses only a certain time of the day, and then they disperse within their community. We get a natural multiplier out there in the communities that people are a little more aware of and how to react to cardiac arrest. But our end goal really is to empower schools to come up and be successful response to cardiac arrest. So we started our program, like I said, in about 2010, and we were the fifth place across the country that had developed a program. We did not have, in 2010, it was pretty rare for schools, and it was kind of an outlier for schools to have AEDs on their campus. When we looked into our community, very few schools actually had AEDs that they'd implemented. So we started, we developed what we think is kind of a one-stop shop for an AED program and implementation. We donated about 40 AEDs to local high schools throughout the state. Whoever wanted to partner with us, we would give them that first AED. We continue to give partial grants on AEDs for schools that want to supplement it. So we'll get a discount on them and then transfer that on to those schools. We help schools with AED accessories. We have a biomed engineering inspection program. We have a compliance and management program. We've helped maintain them. We offer medical direction and oversight. We definitely have a network within the state of Washington and throughout the United States with thousands of schools that have we've helped and partnered with to develop these programs. We help with EMS coordination. We've done CPR and AED training. Now it's if someone calls the hospital and they're asking about AEDs or in school campuses, that always comes to, they say, call Ryan and we'll figure it out. So we definitely in the community resource out there for AED implementation. And so we also have our designation of heart safe school designation that we'll talk a little more about. But this is all complementary to schools out there. There's a lot of for-profit places that offer all this, but we are just here for the schools to help schools have a resource and be able to develop without a funding issue. So certainly AEDs have become commonplace in the cornerstone of the emergency plan. This is a study again from John Dresner out of Seattle that looked at all an athletic trainer, Journal of Athletic Trainers, and it showed that about 85% of schools have at least an AED, and it comes out to be about almost three AEDs per school that have been implemented. These, when you looked at the type of school, it was really the large schools have a easier time getting an AED versus the small schools. The suburban schools have more AED access than rural schools, and public schools definitely have an easier time getting AEDs over private schools. But you don't have to look too far to see that AEDs have been proven in the success rate. So if you look at the AEDs implemented in casinos where most of their individuals are witness arrest because there's so many cameras and they have an identified team, and AEDs throughout the casinos, the average success rate somewhere around 41 to 75%. And there's been some really good data that comes out of these police departments that implement AEDs throughout the community, and they train on them, and they are the first responders and decrease the time to defibrillation. And so these are just proven programs that are out there across the United States that show that AEDs do work, but really that's only the beginning. The surviving sudden cardiac arrest, really the single most issue is the time from collapse to defibrillation. And your rates usually it's been well studied that the rates decline somewhere between 7 and 10% for each minute of delay. And with CPR and defib, within about 3 to 5 minutes, you can increase those rates from 40 to 75% with a well thought out plan. And across the country, it's about, somewhere in about an 8% survival rate of cardiac arrest, just all comers. But we don't want just to see, schools buying AEDs and they become a mount on the wall that sit there and everybody walks by and doesn't understand what they really are. Everybody's heard the stories of, an AED's there, but no one recognizes signs of cardiac arrest. People are often unafraid or unconfident about starting CPR or using an AED. There's oftentimes people don't even know there's an AED on the campus or nearby when a cardiac arrest happens. And then you hear these dreadful stories about an AED not working when they do summon it to, lack of compliance or being checked. But what does the state say that we should be doing out there? These are really, the state of Washington, there are some states across the country that have some legislation and mandates out there to increase the compliancy, but the state of Washington just has the RCW that says the duty of acquirer. And it really says that once you obtain an AED or acquire an AED, you need some medical direction to oversee it. You should train likely responders in a reasonable training with CPR and AED use. You should notify the EMS or at least have a courtesy notification to the local EMS. The big thing really is that a defibrillator must be maintained and tested according to the manufacturer's operational guidelines that we'll go over. And then extend a notification of use to the EMS or the hospital that it goes into. The other things the state asked for is in the last 10 years or so that we now are instructing all our high school kids in CPR instruction before they graduate. And then there is a newer, since about 2018, a newer awareness campaign for coaches that they do some online awareness of what cardiac arrest is in athletes, somewhat like the head injury mandates. I will say that the cardiac emergency response plans is in legislation now, and it's currently being introduced in the state of Washington. And the goal is really that there's some language across the state that schools will adopt a cardiac emergency response plan. And I think that won't probably go through this year, but maybe next year it will be in the legislation around that. So in your own area, this is really all that I could find in the Chelan Douglas County for resources and mandates, I guess, or request. It's really just to reach out to your EMS, and this is probably better than a lot of local areas that they have actually a formal registration for your AEDs. It's more on the EMS side. It doesn't give a whole lot of resources for the schools, but it does provide some oversight and a notification to the EMS that they put on a map, a kind of a Google map that shows the AEDs in your area. So at least the EMS knows about them, is kind of tracking them, and that is much better than a lot of areas that you know, you call EMS and it's more of a courtesy call. So some of the school's responsibilities and best practices after you get an AED is really developing a comprehensive program. And the number one thing is to have a site coordinator on that campus. Second is to set up a routine device inspection with documentation. Schools should have all staff awareness about what the AED is and where it's at and the signs and symptoms of cardiac arrest, and then some signage within the school. And those four things are really the minimal standards that each school should overcome and be able to do if they have an AED on the campus. Now, the other things are best practices, which is notify EMS, develop a cardiac emergency action plan, identify a designated cardiac response team, treat that team or train that team with reasonable CPR and AED training. You should maintain a roster of those so you can do an annual review of them, and then annual practice drills. And then if we partner with the school, we just ask that we develop and maintain a relationship with the Project Adam team so we know you guys are doing your best job out there, and then provide any event data summary and downloads for the local EMS or the hospital that someone goes to. And these are all backed by Project Adam. They're well documented across, you know, some of these big agencies like the Task Force Recommendations for Emergency Preparedness, the American Heart Association, National Trainers Association. So these are well-known and well-documented best practices. So how are schools doing? This was a compliancy check that I did of about 25 schools a few years ago. And, you know, this is actually after we've initiated Project Adam into schools and been working with them for several years. We went back in and to see how we were actually doing. And this is kind of some common things that we found. We found that a lot of schools didn't have a written policy or guidelines. We found that staff were unaware of the location. So we would go in and ask, hey, we want to check your AED. And they would be like, what AED? They didn't even have an idea where it was at. Oftentimes there was no routine inspection setup, or if there was no documentation about it. Many schools did not have any medical oversight. The prescriptions were missing. You're supposed to have a prescription for these AEDs. We found three AEDs that were inoperable out of about 22 or so because of dead batteries. We found one in an AED was locked up in a locked closet. We found 3 sets of pads that were expired. We found one alarm cabinet battery that was dead. But oftentimes it's a very fractured team out there. So the nurse is trying to oversee a lot of this, and there's no I guess there's no team approach. So you got the nurse doing something that's not involved when the athletic department or admin or the safety team purchase AEDs and puts them into the place, and they don't consult with the nurse. Instead of being this whole team on one side, it's all these individual silos throughout the school. Now, when Lana had called me about trying to get this, what your district needed and the ESD needed, she emailed me after that, and one of the nurses had checked. So down there on the bottom, one of the nurses had checked their AEDs and found that they both were inoperable. They both require new batteries and pads, and either expired or set to expire this month. So your ESD is no different than across the state in trying to come up with a process here. So what does it look like when you have the AED equipment? I think all you guys pretty much have the AED equipment out there, or the emergency equipment, and that really is an AED and a rescue pack. And the rescue pack has a pair of scissors in it, has a mouth barrier, has a pair of gloves, what have you, just some simple stuff. I would not try to do a surgery with that little rescue pack, but it is helpful if you are in an event. And that AED or equipment should be easy accessible in your school. You kind of watch these days with how schools get locked up after school, and there's different doors that are locked. Is that AED accessible throughout the day? And then does it have signage, or is it visible from around the school campus? Is it centrally located where it can be accessed easily within a 2 or 3 minute walk? Or do you need to build that? If you only have one AED, do you need to build that into your program that says at this time you have one AED and you're hoping to get more as the funding is allocated? And then, is staff aware of that location? Has EMS been notified? And really, at the end, is that AED ready to be used? And what exactly does that mean? It means that that the AEDs need routine inspections. Every manufacturer recommends what the annual or the routine inspection is, and this is usually about every 30 days. The AED needs to be inspected to make sure and documented that the AED is clean and undamaged and in the spot it's supposed to be. It means that the status indicator has done its self-check. So every AED will do a self-check either daily, about 3 days, or 7 days. And then it will check the integrity of the AED and give a status indicator, either a green check mark, either a green blinking in the right-hand corner, or something to signify that the AED is ready to be used. And then the other things are the pads and the batteries both have expiration dates or shelf lives. And those pads and batteries need to be within those shelf life of the or expiration dates. And if they're outside that, they really should be repurposed or ordered new ones. And so we ask schools, or we recommend schools actually, for the batteries, is to put a battery replace sticker on their battery themselves. And then everybody knows when that battery was placed and when it should be, when the expiration days and when it should be changed out. It's awful misunderstood, or oftentimes misunderstood, that the batteries have a install date on them. And so if you had a new battery and you had just purchased it, there's an install date that you're supposed to install that by. It's usually extended past what the expiration date really is, or the expiring date is. And then when you put that battery into place, you usually only have 2 years, 4 years, or 5 years of battery life left in them. So that's kind of mistook for what the install date versus the expiration date is. So how do we usually see? Most schools are using to check these off. Well, I would say it's some schools use some kind of tag on the AED that just says when they check it, which is fine. Some schools, this was a school that I got just the other day, that they have a in-depth spreadsheet that they go through, and someone checks it off, and they keep a Excel spreadsheet of the AED and all the expiration dates. We offer Partnering Schools a management program that these other ways to do it are fine if you're doing it. They don't offer a real comprehensive management program, and they're kind of cumbersome and clunky. But we offer this to Partnering Schools with that are partnered with us and are developing best practices. And it essentially is an online program, web-based software that promotes compliancy by tracking and documenting the AED information. It sends out alerts to the designated person, and all the information of the AED is put into this website. You got the serial numbers, you got the expiration dates, who the site coordinator is, when they're inspected. It has a alert system with it that sends out alert to that designated person. It can have a hierarchy base. So if that original person doesn't do the checks, it will send it to someone else. And it's all supported by a partner of ours across the country. And so this is kind of what it looks like when you go into the website that is in there. The identified person in the district or designated staff has a username and password, and you go in and you just go in and highlight whatever privilege you had to do the device check. And on the bottom, you can see that at Marcus Whitman, they last did the check on 1/21 of 25. And so it's a good way to document things and keep track of things. And then if everybody can see if it's not been done. Also, it has our Project Adam partner has auto-filled supplies if a school wants. So as those expirations come close, they actually send you the supplies you need rather than being behind the 8 ball where they're already expired and then you're calling to figure out who you're supposed to call. So this is kind of how it looks is we get all the information and then we put it into the website and then send out introductions to it. Next is the signage around AEDs. Now, signage around AEDs really just increases the chance of usage, which we've shown will improve the chance of survival. They raise awareness that a campus has a AED on the campus. It's really, the goal is to direct staff or student or visitors or coaches to the nearest AED. They can be, oftentimes you just see a little three-dimensional sign above the AED that doesn't really show a whole lot. But we really recommend putting directional or location-specific signage up. So when you walk into a school, you can see arrows that point to that nearest AED or the closest AED and gives you some kind of direction. Now, these signs can be somewhat cost prohibitive, but schools come up with their own signs that just say they go in like a sleeve or a plastic sleeve and is put on the wall and they give different directions. Project Adam has signs, Sacred Heart has made signs. There's other signs that schools have made by themselves to give directional signs. And I think it's really important for bigger campuses, that have a big footprint and you may have multiple AEDs on that big footprint, but there's no signage to tell you where those AEDs really are. And the fewer AEDs in a school, the more important it is to have signage and directional signage. So site coordinators, I don't know if, I think I have number 2 on here, but I think the site coordinator is really one of the most instrumental things that a school could have is to designate someone that's in charge of that program. It's really a champion or an advocate in the school. It's someone in the school on a consistent basis. They don't necessarily need to be full-time or there all the time, but they need to be there on a consistent basis. And their job really is to facilitate the program and ensure that the program is doing well. This is most of the time it's volunteered or built into a job description. It really has the most highest level of commitment about the AED program on your campus. I will say in all the schools that I deal with, the most active and successful site coordinators are the nurses are involved with it. So if you get down to kind of the nitty gritty of what the site coordinator's role is, it's really to comply with the RCW of the duty to inquire and implement these best practices on your school campus, provide communication between the Project Adam coordinator and that school. It's a person who oversees that AED program, the response team, and just the generalized preparedness within the school. Oftentimes, the person assists in selecting a response team. That person facilitates and maintains an accurate list of the trains or retraining of this for that team, coordinate or facilitate or even do the routine and annual inspections. That person reports and orders and gets all the outdates, so the new accessories with the pads and batteries. You'll have to be the person who reports the inspection failure. So if that device does fail or have the non-working check mark on it, then you'll have to figure out a way to report that and get it replaced. They do an annual review of the all staff awareness and the emergency action plan, coordinate practice drills. Sometimes they assist in the placement. And oftentimes that site coordinator is coming up with creative ways to generate funds to purchase new AEDs out there. So next would be the all staff awareness in kind of the priority list. And I oftentimes think, you know, a lot of schools are trying to get their complete staff trained in CPR and AED usage. Sometimes that's I think it's wonderful, but sometimes that's cost prohibitive and a big job. But I think it's reasonable and definitely able to have all staff aware of where the AEDs are and what they're actually looking for. And the annual review can be as simple as going into a annual meeting, staff meeting. It can be an email blast. It can be a little letter sent out. You know, there's creative ways to accomplish that annual review where everybody knows the information. And you're just really looking to notify or tell everybody what cardiac arrest is, how to identify it. You know, you may put the oftentimes seizure activities in there or abnormal breathings in there, where the AED location is throughout your school, what the communication plan or how to activate help, and then who the team is. So the cardiac emergency response plans are really it's the most time intensive to the best practices. And schools often have a lot of barriers to overcome to develop this cardiac emergency response plan. Some of the barriers are really, you know, the school or the staff doesn't really, it's a misconception of the need of a well-designed plan. A lot of times we get nurses or someone that's developing a plan and then they move on. So the staff turnover is an issue within schools. You have a high level school that's doing great, and then all of a sudden that person gets married or they move on or they retire. And then the next nurse comes in or whoever the site coordinator comes in, and it's 2 years usually before the school or that person even knows they're supposed to be doing it. And then other barriers are really, you know, schools are meant to educate staff, and this is kind of extra, is to prevent cardiac arrest on it. And they have lots of different priorities. The nurses or these people have a lot of different priorities, being measles and mumps and COVID and lockdowns and all these other drills that you have to do. And then you get staff weariness, that the staff is just weary of adding one more responsibility to their plate. But you know, it's during an emergency or a crisis is really the time to follow a plan and not the time to make a plan from scratch. We deal with cardiac arrest in the hospital daily, and I will say it never goes perfect. And we do it all the time. And so it's best just to have a plan that you follow rather than trying to figure this out willy-nilly. So what does a cardiac emergency response plan or a CERP really do? It is a written document that establishes, you know, specific steps to create increased resuscitation or survivability. And it's a blueprint for the staff to really follow. You can be, the district can have kind of an overview, or the whole district can have a policy or a CERP, and then you have venue specific ones that meet for each building or smaller schools. But the key components are really that it identifies the locations of the AEDs within that campus. It has a communication system for notifying the team or that there's an emergency on that. It identifies the transportation route. It identifies the response team, but not one size fits all. So you can't have a cookie cutter that really meets every school and every district out there. A lot of it is the same, but it does have to kind of be identified for your location. And then once you come up with a CERP, it's best to review it, rehearse it, and modify it as needed. Now, this is supported by, you know, all these big agencies. American Heart supports it, Project Adam supports it. And actually, the American Heart and Project Adam have worked together and just recently to come up with a some common language out there. So it's on both our sites, our websites about cardiac, about the SERPs. So some of the common reasons we hear when we're out there working with schools about the reasons why they don't want to do the SERP or the emergency action plan is the admin or your support people are really unaware of the importance of it. And that, so these are all common reasons that I've heard over the course of 10 years that cardiac arrest doesn't really happen at schools. It only happens to the sick old people that are in hospitals. We have an AED on our campus, so we should be safe. We either have CPR certified teams or we have no CPR people with cards, so therefore we really can't develop a team. We have 911 or the fire departments close by, so they're really our emergency action plan. This isn't really in my job description, is to come up with an emergency action plan on our school campus. We have an athletic trainer that we would call if we had an emergency, or we have an RN on our campus that they're the number one go-to if something happens. And I think those last two, as great as they are to have those healthcare people on your campuses, they're not there all the time. And in my experience, in all those cardiac arrests, the nurses weren't available on those days that they happened. So when you identify a response team, it's really getting a group of people that are identified that are likely responders throughout your school. You want to kind of pick these people and disseminate them throughout personnel throughout the day. So people that are not leaving at noon or all leave at 3 o'clock, you want to disseminate these people or get staff that are around a lot of times through school events, after school events that are there on a consistent basis. And then you'll have a higher chance that someone that is on your response team is there on that likely day. And once you have those identified those responders, you want to train them in the recognition of cardiac arrest. You want to give them some updated CPR and AED usage. It can be either hands only or it can be certified. And it's nice to have the specific AED trainer available when you are training this staff. And then you want to train and familiarize the team with your emergency action plan and prep the team for an annual drill. And then revisit that emergency action plan and that staffing every year. And it's nice to have a system to track the training. Schools that use our First Voice Manager can actually put all that training into that program. So when you train, we recommend really having about one staff for 100 students on your school campus. So if you have 1,000 students in your school, 10 people would be on your response team. If you have 100, it's pretty difficult to have one person there, but if you have 100 students, you don't need 50 people trained for your team. And how this gets done in the training varies across schools. Really, there's 3 different scenarios. One is the school already has an adequate number of staff that are currently trained in CPR and AED usage, and you just identify people that are already trained. Number 2 is really you have adequate number of staff trained in CPR, but they haven't taken the course with the AED. So you really just give them a familiarized or updated version with how to use an AED. And 3, the last one really is the school doesn't have staff trained in CPR or AED usage, so you have to come up with a creative way to train them, either with a facilitation with hands only, and or get someone train the trainer type plan where the nurse is trained and then they go in and train these staff, or you send them out to a Red Cross or American Heart. The communication system on your emergency action plan really is to link all parts of school campus and the response team and the EMS. It includes practice fields and playing fields. It's very venue and school specific, depending on what's out there and what resources the schools have. Sometimes schools use cell phones, sometimes they use walkie-talkies, sometimes they use all calls. Sometimes they have an emergency panic button that these schools use for something. So it's really based on what your school already has in play. Sometimes it goes to the central dispatch or straight to EMS, and then it's a push response back to the school or the staff. But part of that communication is it has a list of the emergency contacts and the numbers. In that communication system, whoever calls, you have a transportation route or identified for the EMS. And if your community has, like Spokane and Spokane County has an app called Pulse Point smartphone app that several schools of ours use that app. And I'm not sure if Grant or Douglas County has that already available. I reached out, Tony thought that some of these places might have it, but it wasn't set throughout your guys' area. So one of the things is the transportation route may change for whatever part of the school you're in. If you have a big footprint on your school or a big campus, you identify a rapid access to enter and exit the school. You identify what the address or cross streets and parking lot, et cetera, is. You designate an individual to go meet that and direct the EMS to where your cardiac arrest is happening. It may differ where you want them to come in, if it's on a baseball field or in the back gym versus the office. And you might have some different access points that are identified. We had a cardiac arrest on the campus of Gonzaga. I think you guys probably all know Gonzaga basketball. Well, there was a young lady playing intramural basketball. EMS got there. She has a cardiac arrest in one of the gyms. EMS gets there in 4.5 minutes, and it took them 4 minutes to find her on their campus. So instead of having a response time of 4 minutes, they had a response time of about 8.5 minutes. So we're trying to minimize that, that response time by getting a rapid access in and out of that school. And sometimes you have to break your school into zones depending on how big the campus really is. You can have different zones set up and different action plans or exit routes or entrance routes or even teams available in these different areas. And then lastly is really to have a practice drill. And the goals of the practice drill is really, it's the best way to assess if your emergency action plan works and if your team is adequately prepared. It's hopefully gather some objective information and times. You set up, it's more of a realistic framework. Now you do get credit, schools are mandated by the state to do a certain number of drills throughout the year, and cardiac emergency response drills can be put into those mandatory drills. It's oftentimes a work in progress, so your first drill does not go as good as some of the additional ones. But as teams gain confidence, you can make the increase more difficulty, being, maybe it's in a chair, or maybe it's under a bleacher, or maybe they have different things on, or maybe it's outside by the bus. But really, it's the increases the likelihood of a good outcome in case of a cardiac emergency. And how you do that is you don't need a whole lot of equipment when you do a drill. You really just need some kind of Annie with a t-shirt or bra, et cetera, et cetera. You can use an AED trainer that is brand specific, where they bring the AED from the cabinet or the housed area to the side of the Annie, and then you trade them out with a trainer. You can put accessories on like medical patches or necklaces, or a bra that makes it a little harder for the staff to get to. You should have a stopwatch or a cell phone timer that kind of gives you time frames of these different things. But you really want a documentation sheet that shows you objective outcomes of this. And to the right there is just one of our school district north of Spokane that does an annual drill, and you can see the times and kind of a documentation of the actual drill itself. So when you do the implementation of an AED drill, you really want to coordinate it with the staff and the admin and the EMS if you want them involved. Now, Moses Lake does one. I wasn't invited this year, but they'd been doing an annual one on Valentine's Day where we've coordinated with the EMS. And so the local EMS comes in at the end of this drill and actually takes over, and they do they do a practice with a cardiac arrest in the school. So they do the whole team where the team comes in and takes over from the staff, and then they transport it. So you can coordinate it with local EMS to do a full day or a full drill. It's really a review, have your staff review what the emergency action plan is. You share the plan with your team. You can do a tabletop exercise where you send this out via email or some kind of paper trail that gives your team the what this is all going to do. You can announce the day or week and say, hey, on this Tuesday, we're going to have an AED drill, or this week we're going to have an AED drill. I would recommend doing that, especially in the early onset of these. We had one of our schools north of Spokane in Deer Park that they would do one announce day drill and then they would do a surprise drill. And the staff was the first one, they were very angry about the surprise drill. It was just a all call all over the intercom, and everybody came running, and then they found out it was just a drill. But it's best just to communicate all those things with your team before you set it up. And then execution, you find you get your Annie, you set it up in a determined location. You have your AED trainer with the objective observer. You engage your staff into a scenario. You make an initial call to alert the team. The team comes and you run through the AED drill just like what you see. And we really recommend that the RN or the site coordinator should really be the overseer of it and not part of the action plan or involved in the CPR and the AED usage. And then you do a post-drill debriefing. And this is all educational for your staff to get objective viewpoints of it and see how the drill went. You can get feedback from your team. Usually we have some great feedback from teams that especially as things go along. I remember one of the first ones that we did, the team stood up and he goes, okay, how much did we screw up? And so their times were all off, and they were very open to it and actually enjoyed it. One of our nurses recommend using the praise sandwich approach when you do the feedback on them. And really it's you give positive feedback and then constructive feedback and then more positive. So it's a more of a approach that teams can take away and feel good about it. And then at the end, you update your action plan if the action plan is not going to work for your drill. So here's some of our results over a course of schools doing this. One of our schools realized that their communication was an overhead page, and they realized that staff get so weary of the overhead page, they're listening to it all day long about Johnny, please report to the office, or so-and-so's outside, or what have you, that they were tuning out the announcements, and the delay was getting the response was getting delayed. So they came up with a specific tone for their emergency, which prompted the staff to be a little more tuned in. One of our schools came up and realized that there weren't room numbers on their classrooms, and the school layout was challenging, so they addressed that. Many staff were the notification education. They needed a little more notification and education about what cardiac arrest is and what they were supposed to be doing. We did find that the more drills really increased the confidence, and overall the response times have improved. Here's a objective data from one of our schools that said the first year the drills performed, the average time to first shock was about 7 minutes. 4 out of 5 drills, the team members forgot to turn on the AED or put the pads on wrong. Year 2, the average time to the first shock was 4.5 minutes. And then year 3, only one person forgot to turn the AED on briefly, and no one put the pads on wrong. And so we had an additional school that did one out on their practice field, and they realized that part of their team or part of their response plan was they were going to send a young student athlete runner to the into the building, and they did the drill. The student took off. He came back about 20 minutes later and didn't have the AD. And they said, well, what happened? And he said, the doors are all locked. And so they updated their plan to include an additional AED into the track field or track shed out on their practice field and design their emergency action plan around that. So what is the nurse's role in all this? We want to see the nurse provide and disseminate Project Adam info throughout the school and advocate for the importance of not only the placement of AEDs, but implementing these best practices that are identified. And the nurses serve in a leadership role as coordinators for health programs, and cardiac arrest prevention really should be included in that. The nurses really are the resource for planning, the comprehensive management for schools, and the policy and procedure implementation or development to help develop the emergency action plan. Overall, they should be the ones to monitor the readiness and determine how prepared a school is, facilitate practice drills. Oftentimes they collect data or at least identify some of this data from the drills. And I would say in most cases, most successful programs, the nurse acts as the site coordinators, but not in all schools is the nurse the site coordinator. So I would challenge all of ESD 171 to become a heart safe school out there. We have the heart safe school designation checklist on our website that you can go download and look at it. And really, it seemed a little overwhelming, but if you follow the Heart Safe School checklist and you do an assessment of where you guys are at now, and you get those goals, is to turn all the no's into yeses. Sometimes this takes, depending on the motivation of the school, sometimes it takes 6 months. Sometimes I'm working with a school down in southern Idaho right now that's took them about 2 years to implement everything. So it's just a matter of implementing and getting these challenges to turn the noses into yes. And then step 2 is really to develop your plan. Follow along on the Heart Safe School website. It's got the templates and resources. It has it's got a kind of tools and walks you along and ideas how to overcome some of these barriers. And then 3, practice your plan. So a plan really is help to improve the response. It improves confidence, and in the end, it saves lives. All schools do tornado drills or fire drills, and it requires the whole school to participate. Emergency AED drills really only takes about 5 or 6 people to be involved in. Our schools typically do 5 fire drills a year. There hasn't been anyone die of a fire since 1958, although we do all these drills. And since about 2000, Project Adam had about 250 lives saved from sudden cardiac arrest in heart safe schools where practice plans existed. I'm going to show you a video. Hopefully this will come through. And this is a Project Adam school in Atlanta. Young lady's name is Claire. She's about 16-year-old. And you can watch the timing on the bottom right-hand corner of how this resuscitation really goes. So the AED shows up in about 30 seconds. Someone's given CPR in 1 minute. She's shocked in 2 minutes and 30 seconds. And she had responded spontaneous circulation within about 5 minutes. EMS arrives in 10-12 minutes to transport her. And this kid was alert and awake when she got to the hospital. So kind
Ryan,
of a chilling event out there.
sorry, Ryan, was that school and a Project Adam school?
That school was a Project Adam school that had been designated heart safe.
That's amazing.
Yeah.
Just really quick, I was wondering if any of our nurses, if you have any questions for Ryan, please, we'll get you his email address. I think it's in is it in your slides?
I'm not sure if it's in here or not, but I don't think I have it in here today, but I will certainly send it to you
Awesome.
for any contacts.
Yeah,
Questions.
if you don't mind, I'll be happy to send out your contact information. So
Yeah,
if
great.
we have if any of the nurses have any questions for you or want some more information on the materials that Project Adam can help them with, that way we can facilitate that connection with you.
Absolutely.
Awesome. Well, I really appreciate your time with us, Ryan. Thank you so much. And I just saw someone said, yes, please, to get you their contact to
Yeah,
get them.
anything else? Is there any questions that I could address while I'm here? Or does anybody have any questions for me? I'm welcome to you can contact me outside of this or call me, email me, whatever's easier for you. I I encourage you to look at the website and start to kind of go on that route. And all our resources are here for you. I will say I get inundated with schools, so I'm one of the only Project Adam coordinators that have a full-time job in a hospital, and so it's just a battle every day about getting this. But that's what we're here for, and hopefully we can get you guys a little more compliant.
Awesome. Well, thank you so much. We really appreciate you being with us today, Ryan.
Yeah, thanks for the
Really
time.
much. There was a comment in the chat about how you have been helpful in instigating a plan. It looks like in Soap Lake with Jody. So we have lots of people that have already been beneficiaries of
Yeah.
your work. So thank you so much. We really appreciate it. And I'll make sure that we get your slides and your contact information for our nurses. So thank you again.
There was one question in the chat if there is a recommendation for schools and how many AEDs they have on their campus. The American Heart Association recommends having a brisk walk from AED to AED. So depending on how big your campus is, you can blanket those. What I see is very few schools, I guess, fund that many AEDs out there. So I would recommend, having one AED and then building your action plan around it. And then in your policy, really addressing that to say, at this time, our school is implementing one AED, and as funds become available, we will entertain the idea of putting more in there. But it's really more of a funding thing. If schools can afford it, the more AEDs, the better, I guess. But having said that, each AED takes about $250 every 4 to 5 years to maintain. So it's not just the upfront cost of the unit. Then you have to plan to keep the pads and batteries, within those expiration dates, and it costs about $250 every 4 to 5 years per AED. So there's
Thank
not
you.
really a recommendation, but the AHA does say that more than one's better. So
All right, thank you so much.
you bet. Thanks
We
again.
are running a little bit over, we are running overtime, so if there's other questions for Ryan, if you wouldn't mind, I'll be sending out Ryan's email to you today, so that way you can email him directly and we can get you connected and on the path of becoming a heart safe school.
Great.
So thank you
Thanks for
so
the
much
time.
again.
See you guys.
Thank you so much. I really appreciate it.
Yep.
All right. So Kristen, sorry, I kept trying to call you Kirsten. Sorry. So Kristen Hosey is with us in place, standing in for Dr. Wallace today. So I will turn the time over to her. So I appreciate you being here with us and all the others that are representing our health districts.
No problem. Can you guys hear me okay? Cool. I actually am going to keep it pretty short because we have some cool stuff happening and I don't want to take the spotlight away from my staff that are working on some surveillance information. So first I have here Garth Donald, who is our behavioral health and substance use coordinator, and he's going to give a short update. And then Elizabeth Austin is our regional epidemiologist, and she's going to give a short update on our respiratory illness and where we're at right now, being in the flu season. So, and I have a TB nurse position open, so not asking for you guys, but please tell your friends. So those are my updates. I'll turn over to Garth to give his on our overdose and opioid work.
All right, thank you, Kristen. Yeah, my name is Garth Donald, Behavioral Health Coordinator with Chelan Douglas Health District. One of the things I do is monitor overdoses in the region, as well as help the community respond to them. So just a quick update. You may have seen news that we were having a lot of overdoses recently. It started in November and kind of went through December and January as well. We have been working very, very hard to update or build from the ground up our tracking services, both with hospitals, EMS services, with the coroner, as well as kind of some regional emerging trends. So we're able to see what's going on a lot better than we were at the beginning of last year. I will say, looking at hospitalization rates, it looks like that spike that we were getting in November seems to be over. The numbers are down back to kind of what we are used to seeing in the hospitals. So it's been going on for 2 weeks now that we're back at normal levels. So definitely glad to see that is occurring. I do want to stress that overdoses are in our region, the leading age range for overdoses is 65 to 75. This is something that is happening within our elderly population for a number of reasons. 15 to 24 is about in the middle of the pack. Unfortunately, I'm not able to split that into 18 and under at this time, but I will try and get that information for you guys moving forward. You may have seen that we did a press release recently about the source of a lot of the overdoses that we've had this last year. 2024 was a heavy year for us. We worked with the coroner to look at a lot of these reports, and we found there was very heavy overlap between methamphetamine use and a fentanyl overdose. And in a lot of these cases, we suspect that these were accidental overdoses. These were with folks who were not aware they were consuming an opioid product. And so use this information with whatever you think is best. But if you happen to work with students who might have parents or family members who use methamphetamine, like, this is kind of something we're trying to monitor and stay on top of and get a warning out to. So far, so much of our efforts have been talking about overdose awareness and naloxone access to people who use opioids. And at this point, we're realizing this is a different population that we need to be looking at is folks who use methamphetamine. So hopefully that's not an issue that you deal with a lot with the students under your care. But I do really want to stress this is where 2024's overdose problem was coming from. And again, we think that it's folks who were not aware they were taking this. I can't tell you any further because we don't have the testing resources to know why that's happening, but it is very clear there's a strong connection there. Outside of that, we will have, I know that you guys have overdose reporting forms available. So in the past, when there was an overdose, you have a form that would be sent to the Drug and Alcohol, the Center for Drug and Alcohol Treatment here in Wenatchee. We are almost finished putting together a new online reporting form. It should be easier to use. The information will go to the center as well as Chelan Douglas Health District to help us track what's going on better. On top of that, I'm sure you guys are all well plugged into naloxone and having it available in schools. Naloxone reverses opioid overdoses. Much like AEDs, I do recommend that naloxone is kept in a kind of a centralized location, that staff are aware of what it is, how to use it. It's a fairly straightforward medication, but as you know, in cases of emergency, you just want everyone to be able to quickly respond. We do offer here at the Health District, we do offer naloxone trainings. Happy to provide that to staff. We can come into schools if you prefer, or do it online, whatever works best for you. I'm going to attach our training form that we have up online, as well as my email address. Feel free to reach out directly to me. We have a number of staff who are trained to train others in naloxone administration. And yeah, if you have any need for it, we are there for you and happy to provide it. And that is my update for the month.
Go ahead, Elizabeth.
Okay, great. Thanks, Garth. Hi, everyone. My name is Elizabeth Austin. I'm the regional epidemiologist here at Chelan Douglas. So I've been working closely with Garth on the overdose reporting. As he mentioned, we have this online survey and an updated PDF version of that same form that we'll be coming out with soon. So stay tuned for that. And let me see if am I able to share my screen? I think I'm able to. Hold on one sec. I'm just going to pull up our respiratory numbers here. Okay, and everyone can see this okay? Good. All right, so we have a county-specific version of the Washington DOH dashboard for viral respiratory illness. So I just wanted to walk through what some of the trends are that we're currently seeing. So this viz here shows hospitalizations and emergency visits, and these are broken down into percentages for each pathogen. So for COVID-19, we're currently seeing somewhat of a downward trend. So we're at about 0.9% of COVID-19 hospitalizations for Chelan Douglas, and that's out of all hospitalizations that are reported by facilities in our area. And then for ED visits, also seeing a downward trend related to those. So it's about 0.7%. And then for influenza, for hospitalizations, this shows somewhat of a downward trend here too, but it's still at about 2.1%. And in previous weeks, we were up at about 3.9%. It looks like maybe towards the end of January. And in December, end of December, it was at about 4.7%. So still not quite the same peak, that we saw back in December. But again, these are hospitalizations. And then if we look at emergency visits for influenza, we're showing about 3.5% of total emergency visits are related to flu. And then for RSV, seeing some sort of erratic trends there. This shows a recent uptick for last week. One thing I'll mention is the data shown here. This is updated every Wednesday by DOH. And so this data also shows the week prior. So the most recent week of data we're looking at here is February 2nd through February 8th, just to give some context. So that's at about 1.3%. And then for emergency visits for RSV, it's showing about 0.4%. But we also have an influenza-like illness report that we're able to run, and this shows more recent data. So this is showing data that goes up through the end of this past Saturday, so this previous week here. And so this data, this report shows influenza-like illness visits, which ILI is defined as a fever, a temp of 100 degrees Fahrenheit or higher, plus cough and or sore throat. And so this data looks at any influenza-like illness visit based on whether someone is a resident of Chelan or Douglas counties. And that is based on how they're presenting to a healthcare facility with either a chief complaint of ILI or a discharge diagnosis of influenza. So this report here looks at ILI related to influenza as well as RSV. It doesn't distinguish between COVID-19. It just looks mostly at the symptoms of influenza-like illness that patients are presenting with. So here, this first graph shows the percent of ED-ILI visits by week. So you can see we had our peak, closer to the end of the year, beginning of the year back here. And then we're showing kind of this slight increase again. And then hospitalized ILI visits, those are also a little bit on the downward trend side. One thing to keep in mind with the data, especially related to hospitalized cases, is sometimes there's a reporting lag. So these trends could certainly go upwards in the coming weeks. And one of our more apparent indicators here is the percent of urgent and primary care ILI visits by CDC week. So you can see here that this has definitely shot up within the past couple weeks. So it's at about above 5%. So definitely seeing a trend upwards there. And then we also have these ILI visits broken down by age group. And you can see here the pediatric age groups are trending the highest with the 0 to 4 and 5 to 17 age groups significantly climbing there. And then these last two graphs show the percent of ED-ILI illness and influenza visits by CDC week. So the interesting thing to note here is this is looking at ILI compared with those visits where they may have actually had a positive test for influenza or diagnosis for influenza. So you can see here that these are very similar in terms of trends. And so this shows that influenza definitely seems to be the driver behind, the respiratory illness trends that we're seeing. And then here, this last graph shows RSV ED visits. And you can see here, this scale is much smaller. So this is on the 0 to 1% range. So you can see here that it does seem to be picking up a little bit. It's not quite as high as it was earlier this season. But there does seem to be maybe a little bit of a plateau, and we'll see how that continues to trend. And then the last thing I'll mention is just that with all of the influenza activity, I think there's been a mixture of subtypes that have been reported. So it's been a combination of flu A, H1N1, and H3N2, and then smaller amounts of B. So it's primarily flu A, kind of waiting to see which of those subtypes are dominating. I think the last time I checked, it looked like H1N1 might be eking out H3N2, but yeah, and that is all I have. I'm happy to take any questions that anyone may have.
The other piece that I'll add on here is Elizabeth is working on developing this for our region so that currently on the Department of Health website, you can get some of this data, but it's divided up by the ACH regions. So we're trying to get it down by county. So we'll be adding Okanagan in soon and Grant and hopefully Kittitas. So in the coming weeks, that is something that's one of our projects. I see some questions in the chat around staying home. I have to double check on the dates, but usually if they get connected with the provider's keeping the kids, anyone home for a certain period of time for after symptom onset. I have to double check. It's 7 days. I think it is 7 to 10. Another piece to add that I just wanted to wrap up for today is we have continued our notifiable conditions series, and if you missed the one in February, I can show you exactly where to find it on our website. If you go to our website and you just go to provider page, it'll look like this. It's got a little bit of info, like you mentioned. We were asking about the flu. You can look at some of the information on flu. But if you go down here, you can see the list of our provider alerts, as well as our notifiable conditions. So all 4 of the notifiable conditions events that we had last year are recorded and up on our website. And that includes Q fever, rabies, measles, and pertussis and syphilis. And then our last notifiable condition was about overdoses. And so that presentation is up. Our next one will be, let's see, February, March, April, May. It'll be the first Thursday in May at noon on Zoom. So if that's something that you're interested in, you can shoot us an email and we'll put you on to the list for getting those updates. And so that is kind of I think those were my 2 big things that I wanted to share in absence of having Dr. Wallace. He's out this week, but I can ask him questions.
No, that's fabulous. Thank you so much, Kristen and Garth and Elizabeth. We really appreciate you being with us. And I'm going to circle back to you a little bit or after our meeting, Kristen, and get the answers to that question about staying home, the time frame. I also wanted to make sure people saw in the chat that there is something from Amber McCoy from the Grant County Health District that in Grant County they're still seeing pertussis cases. So keep that in mind. Kathy and I believe it was Amber both put more resources for Grant County and Okanagan County in the chat as well. So you can, these programs and these trends that Kristen and Garth and Elizabeth were talking about, you can find those also for your specific counties. Ben, you had your hand up really quick. What's up?
I was just going to say that on the Department of Health for what to do when you're sick with COVID or other respiratory, it does say 7 days and then follow precautions through day 10. So that's probably the 7 through 10, and then no fever and symptoms improving.
Awesome. Thank you so much. I appreciate that. All right, well, let's go ahead and turn the time over to Kathy, and I will make sure I get an email out to everyone with the follow-up on those specific questions from everyone for Kristen and also Ryan's contact info. Thanks so much for being with us. We really appreciate it.
Okay, let's continue on then with some, we're going to do some North Central ESD quick updates and then move into some updates from Washington State. So first of all, I'm going to talk very briefly about the district assessment, and I want to congratulate Ben. Ben wave your hand so that everybody can recognize you. You were the first person to submit your district assessment this year. So thank you very much for doing that. We've gotten about 4 or 5 of these in, and just as a quick reminder, the due date is April 4th. So if you need help with your district assessment, do let us know. We'll be happy to help you complete that. So again, a reminder, all of your tools that you need to do it, including the district assessment tool itself, your instruction sheet, which we really encourage you to read, are all listed in the Google Drive. So you shouldn't have any trouble accessing the information that you need to get this project started. A couple of questions that have come up. This was a new question that was added this past year, and it has to do with 504 plans that are specifically related to health conditions. So if you have a student who has, let's say, who has anaphylaxis, for example, and that student also happens to have a 504 plan related specifically to their health diagnosis, then we would like you to count that. Now, if this is difficult for you, if for some reason you're challenged to identify which of your students have a 504 plan specific to a health condition, we ask that you not let that impact your ability to count your plans. If you don't know the information and you cannot access it, then it's okay this year to skip that. But we really would like to begin identifying how many 504 plans are in existence that are in support of students and their chronic health conditions. So you'll see that over here on this far right-hand side of the slide, there is an area where you could list a count of 504 plans, and those 504 plans are just specific to these particular diagnoses or others that you have not listed but want to count on your district assessment. Another section we seem to get questions about is this contributions and health services gaps question. So these are towards the end of your district assessment where we ask you what you've been able to contribute to the school so far this year. And we know that it's not the end of the year, so we don't expect everything to be done. And or ever to be done if you don't have time in your day to do it. So we're asking questions about whether or not you've been able to contribute a variety of things to your school district. And then in the same section, we ask you if you have had difficulty accomplishing things within the school district, and where are you at in terms of several things on a list that are generally identified with school nurse role and responsibilities. And so just a quick review of that scale, it's high, medium, low, or met. So if it's high, it's asking about, it's a high need. In other words, it's something you haven't got to yet that is a high need for your district to be done. So let's say it was medication policy, training, delegation, and ongoing supervision. If that's not done yet this year at all, that would be a very high need. And so you just put an X in that box. If it is something that is listed on here and you have not done it, or you think that it's not your role to do it, then you wouldn't put met, because met means you have done it. So just as a quick reminder about both of these scoring sections, this is not a grade. So it's not a measurement of your activity. It's not a measurement of your productivity or your knowledge or skills. It's really just looking at, based on the time you have available, what on here were you either able to contribute or accomplish so far this school year. So please do not hesitate. If you have not done something, please indicate no. If you have not met something, please indicate where it is on a scale of importance to your school district to complete it. And please limit your responses that say met to things that are actually 100% met for the school year. Okay, so that is all I wanted to update you on North Central ESD. That's what we're working on right now, is getting those district assessments done and going through them and asking you questions just to clarify the information that you're sending back. So at this point, you might be hearing from us about whatever has been sent in, and we're going to help you with it. So some DOH and OSPI updates to get through. Last month, we talked about the immunization survey that's going to be going out to school nurses and administrators, asking for their input on immunization compliance and how well they're doing with that, and what kind of practices they have found to be successful in regards to shoring up immunization compliance in their school, or what kind of challenges they're having. And that survey is just in the process of being finished up. It is due to go out on the 26th of February. So begin watching for it soon. You'll have 2 weeks to complete it, and please work with your supervisor or your superintendent on this document. And Department of Health has been working on this tool, and I think they're going to get very useful information when they get these all back. A couple of other updates from immunizations. I just wanted to give you a heads up that there is this new tool that's available. It's called Vaccination Summary and Forecast. This little tool takes you through the process for obtaining summaries or to reviewing forecasts for your individual students. Some of you might have seen this in the past, but there's now a new little guide to help you with this. I wanted to point out the fact that Department of Health has short training videos on a lot of these little tools. So for example, if you're not used to looking at your summary for your students or individual student forecasts out into the future to give you a heads up on what is coming up due for a particular student, then not only does this like 4-page guide show you how to do it, but you could also watch a very short training video, and that would help take you through that process as well. So Department of Health has been working very hard in the immunization area to improve their training, both their videos and their tools that they're creating. This gives you an idea of what the forecast looks like, for example. And so you can just take a look here, and this will give you a heads up of what is coming up, what is past due for a student, so that you could start preparing them. And again, short training videos are available to help you with this. The other thing I wanted to point out also, besides the training videos that they have available, is this nice newsletter. I don't know how many of you currently receive it, but I would encourage you to start subscribing to it. So there is a link here in the PowerPoint slides, which you have access to, where you could click in and tell the Department of Health that you would like to subscribe to this newsletter. It will come to you monthly by email. The other thing is that there have been some updates to the school module training materials, and you can go in to access those through the portal, as well as all these video trainings that are available to you. So one of the other new things that they've just recently put out is on adding, editing, and deleting vaccines, and there's a short video on that, and they're continuing to work on additional training materials as well. Another update from Department of Health. This one is on just a quick overview of some of the department environmental health updates that they've been doing recently. In the fall, they did a couple of workshops, one in Renton and one in Spokane. One of them was recorded, and you can access the all of the individual workshops. You can just click this link and go into all the recorded sessions from these fall sessions. They've also been adding to their Washington Department of Health environmental section of the school page. And so if you log into the school page and you scoot down to enhancing safety and in health environments, you'll begin to see lots of information that's been added to these different sections. And one of the things I wanted to point out is these pest press reports. We do get calls at times with people notifying us about, pests and where would they get information, about bats, for example, or rodents in the school. And Pacific Northwest Pest Press has been a shared tool that Department of Health has been working on with University of Washington. And they're going to be expanding this effort, and you're going to see more of those. You can actually link to all of the products they have available under this animals pest management and pesticide section, as well as other training materials as well. So just something to be aware of. Another recent tool that has been posted by the Department of Health is the School and Environmental Health and Safety Guide. And we may have mentioned this before, but I just want to make sure to point out that the newest version of this actually does have a small section in it that addresses school health rooms. So school health rooms are mentioned in the WAC codes, and therefore, because they are in the School Environmental Health and Safety WAC, you can find some language specific to them in this new tool, and it's on pages 25 and 26. And here's what it describes. For a school facility that has a designated health room, the school instructions are really about what that school health room should include. And so this is just a quick list of making sure that there is privacy, but also that you can have some ability to visualize students who are using that room, particularly when they're going to be using that room as a sick room. Make sure that surfaces can be easily washed. A hand washing sink should be in the room. An adjoining restroom should be attached to that health room. And there should be a ventilation system that's set up in there to have good airflow in that room. So this is pretty new. We haven't really had anybody talk much about what a health room should consist of. And so it's nice to have at least this level of guidance in that. And it's certainly a resource for you as you're talking with your superintendent and supervisor about the needs of your own health rooms and what Department of Health recommends for them. Weather safety, we were talking about weather safety earlier, and here are a couple of tools I wanted to make sure that you're aware of. One is a child care weather watch, and this comes to us from Health and Health Services out of Iowa, and we've been using it for some time, and Department of Health in Washington continues to encourage us to use this Iowa tool. This is actually a multi-page tool that talks about both heat and wind chill factors to keep in mind of when it's okay to send kids out for recess and when you should keep them inside, whether it's due to heat or cold temperatures. And then this nice cold weather safety webpage has many tools on it. And this was just recently posted in the Chelan Douglas Health District's newsletter that hopefully some of you are subscribing to that as well. And lots of tools in there. I wanted to make sure you're aware of a new change that's coming through. This is also an update from Department of Health as well as from the WABON Board of Nursing. And it has to do with how we update our licenses, how we look up licenses. So it's essentially going to be a replacement for the current Washington Department of Health licensing software program. They're going to be replacing, it's very outdated. We have an outdated system. It really can't keep up with the demand of all the things that it's supposed to be managing in the state of Washington. And that's not just individual like nursing licenses or physician licenses. It really goes into licensing of healthcare facilities and healthcare programs, educational programs are all run through this kind of antiquated system. So Department of Health has a new product and it's referred to as HELMS. It's the Health Enforcement and Licensing Management System. So this system is going to replace the old one, and it is supposed to create efficiencies. It's supposed to make things easier for all of us as we either look up licenses or even work on renewing or making revisions within our own licensure. So this is just a little bit about the numbers of things that are currently being managed across the state. So another good reason why the old system really needs to be replaced. The current status of this, it was just tested. So if any of you actually tried to log into the system over the last 2 days, you might have experienced some problems because they had to turn everything off while they did some testing of the new product. And so they have done some testing. The old system still remains now running and the new system has not been turned on yet. They're going to be doing some more modifications to it and some more staff training. And hopefully that will be up and running here here within, I don't know, I would say maybe within 30 days, but a notice will go out when it is available. Just as a reminder, you do need to have a SAW account, and I'm sure all of you do, but Department of Health has asked that we remind everybody that you need to have a SAW account in place in order to log into the Helms user account. We talked last week about some of the bills, or last month about some of the bills that are coming through the legislative session. So today is the 18th, it's day 37. So I have 68 days left to go in this session. And as you've heard, there are a number of bills. These are just some links for some training materials to help make sure that you understand a little bit more about bills and how they come into place. One of the ones that's recently you're hearing perhaps a lot about in the news is I-2081, and this is the Parents' Bill of Rights. This actually law went into effect last year. So this is kind of a little bit about how bills work. It went into effect 6/6/24, and someone immediately put up a lawsuit against it. So a lawsuit was filed to try to put a block on this bill because there was language in it for a variety of reasons. One was because it conflicted with other laws that were already set up in the state of Washington. And also it conflicted with some of our minor consent and confidentiality laws. So the lawsuit was filed. And therefore, as a result of that, the bill was put on hold. So during that time, we continued with all of our old practice up until January, when the lawsuit was dismissed, and it was found that I-2081 did not violate the Washington State Constitution, and therefore at that point then, as of February, became in effect. Now, OSPI is tasked with providing us with guidance on these bills. And they put out a bulletin, and it's number 00925. I did receive that on Friday and emailed it out to everyone. So you should have a copy of that so that you can see what schools are being told as far as implementation of the law as it is today. So OSPI is not only tasked with trainings about it, but also with making sure that we are also aware that there's still a lot of debate going on about this law, and that other folks have sent in bills to the state that they would like to amend I-2081. So they would like to make some changes to this, and we'll go through what some of these are going to look like. But just know that there are 3 current actions before the legislature that are being looked at that would all create amendments again to these laws. So some of the things that this is asking, some of the changes that took place, well, one is access to student records. And we do have laws in place about access to student health records. And most of our concerns are really around access to the student health records and what parents should be able to obtain from the schools, and then what is confidential for the student. Because as you all know, we do have rules and laws around students' access and ability to request their own healthcare, different types of healthcare at different ages. And so we're just wanting to make sure, as a state, that our laws that we are setting up are actually, they are in alignment. So we don't have one law telling a school district one thing, and then we have a separate law telling something else. There was some kind of, as soon as the law was passed in June, there was some immediate confusion about what it meant when we had to give parents had to receive prior notification for medical care provided within the school, and what that meant and what it looked like. So there were immediately questions about how this was going to be implemented in the school. So there is still an opportunity, if you have had an opportunity to review the bill, to review the laws. If you have questions about these things, you can read the initial guidance that came out last year. You also have the new guidelines, which take you through the laws, kind of individual sections of the laws step by step, and talk about, okay, this is what this really means. If when it says this in the bill, this is how it would really be implemented in their school district, and this is what the schools should be doing. And you also have an opportunity to give feedback on this. There is a Parents' Bill of Rights survey that is maintained on the OSPI website, and they are still continuing to collect data from that. With their posting it so everybody can see the comments that come in, or kind of a summary of the comments. This is a report from November of 2024. We should be able to see December's, should be posted in there soon. And this is a multi-page document that will take you through. These are the kind of concerns that people have about this bill. So that might also kind of give you some direction on what you'd be looking at. And bills that are in place right now: anaphylaxis and epinephrine still being discussed, school nurse mentoring support still being discussed, adrenal insufficiency care and how that would be provided in the school setting, and could it be provided by a PDA? That's still in discussion. And et cetera, et cetera. And then we have, of course, the cardiac arrest one. So we still have a number of bills that are in some kind of process, and we'll keep you up to date on how things are going along with those. So now you've gotten to hear about the Heart Safe Schools and cardiac response plans, and that opportunity that is available to participate in the ADAM project. So just a quick update on the AED grant process and the grant that we have had available. We had 282 units requested across the state of Washington, and unfortunately there was not funding for that many. And so the applications were all reviewed, and the grant was awarded to 44 to purchase 44 units. So if you had submitted a request for one and you were awarded one, you probably will be getting your notification within I would say within the month. And then I think it was a good eye opener for OSPI as well as some of the other agencies to really see the need that's out there. You know, how many districts actually were in need of AEDs, and to look for perhaps some additional funding to provide more support for them. And then as a reminder, if you're looking for information about the cardiac response plan and how you might set that up, as well as information about Project ADAM and the Stop the Bleed course, we have tools and materials available for you in the Google Drive under Toolkit, CPR, AED, First Aid, and you can find them there. And we talked about bleeding control equipment in the past. And just as a reminder, if you are not familiar with Stop the Bleed program, if you want to practice your skills on Stop the Bleed, do get in touch with Lena, and she could set up some courses and help with Train the Trainer training. So we want to make sure that you feel strong and supported in that. Health equity training, just a reminder is that if you're coming up on your license renewal date, that you will need to get 2 hours of health equity training completed. And so if you click the link on the slides, it'll take you to courses that have been approved for that training, and you can get that done before your next license renewal. And then after that, it will become an annual requirement for license renewal. Waybon asked that we also update you on some of their frequently asked questions for those of you who go to the FAQs on the Waybon site, and there are many of them. They have done some updates to some of their opioid FAQs, again, largely to try to clarify and to add as more questions come in about from either registered nurses or other licensed personnel about naloxone use in the schools. Quick training events that are coming up, just to give you an idea, things to be thinking about. We've got monthly programs coming up such as DISH. Tomorrow's DISH program is going to be focused on mental health issues. We've got best school nurse roundtables. We've got 2 more of those scheduled this school year in March and in May. We have some Skyward and cumulative training coming up. The next one we have is 317. Those are 2 separate trainings, but they're both on the same day. And both of those are going to be addressing health records. So if you need additional training on either Skyward or cumulative in regards to health records documentation, March 17th, there will be a training program. Both of those are going to be in the morning, and you can find the links to register on the Google Drive calendar. Snow Spring Conference is coming up in March. DOH School Nurse Connects is coming up in March. We have a CPR first aid course in March, School Nurse Workday in May, and then our final Best School Nurse Mentor session is in June. So lots of things coming up. And so keep an eye out on the calendar. This is not everything, but these are some of the larger events we have scheduled. A reminder about the ESA certification. The next course we have scheduled is a UW Foundations course for school nursing. So this course is set to start March 31st and is now taking registrations. So there is a link to get to the access form, and Sheila also has access to that. So you could get in touch with her if you would like information or a flyer for that program. And coming up on the end, just as a reminder, that there are scholarships available through this through SNO, and those are open to anyone who is a member of SNO. So if you are looking for either a grant that you would like to use towards, let's say your use it for, let's say your you want to attend a conference, you want to attend a SNO conference, just know that there are grants that you could apply for and they're very simple to apply. So those are available. And then there are also awards. The awards are coming up. We do those at the spring conference. And so we have until some early April, I think, to submit any one that we would like to have considered for an award from our region for one of the school nurse awards. So those are coming up. And then finally, I just want to say, because we're at the end of our time, that I know people, again, they are under lots of stress on a day-to-day basis. And I know people sometimes think, oh, I'm not doing this right, or I'm not doing a very good job. And they get kind of caught up in, you know, whether they're doing their job right, and they get very stressed about that. So this is from a trauma course, and I think it's really valuable for all of us. And the statement is, forgive yourself each night and then recommit in the morning, so that you're not just constantly stressed and feeling like you're beating yourself up over and over again, but that you make sure to not only cut yourself some slack, but other people that you're working with as well. And just recognize that we're all doing the best that we can on a regular basis, and that each day is a new day, and that we can then recommit ourselves and our energies to doing that best job we can again when we start out a new day. All right, so that was fast and furious. If you have questions about any of those things, I'm happy to either answer your questions, or you can email me. There are things that are in flux. I really appreciated the request about, is it 7 days or 10 days, or what is that? And Department of Health has heard that as well. They are coming out with a new one-pager in multiple languages that we're going to be able to, I checked, but it's not posted yet today, but it should hopefully be coming soon, that you could distribute out. And it is going to be the kind of that community COVID response of when to do what, and in very simple forms that you could use throughout your schools and share with parents and students, etc. So they recognize it and are trying to come up with many new tools, and they are working on those things.
Great. Thank you so much, Kathy. We really appreciate that. And all that you do for us in the region. Thank you. There was a couple of things in the chat. Carrie Harris, our SNO area rep, put in information about the link for the voting for the open positions on the snowboard. So you should be seeing that in your email, or in your inboxes. Erica's from Lake Chelan was wondering about if we're in an even or an odd area. Correct me if I'm wrong, Kathy, but I believe we're in area 9. So yeah. So Erica, that's our voting area. So I just wanted to share really quick, because I know that we're out of time today. So thank you for being with us, and just wanted to remind you that anyone that's watching this as a recording, the only way that we can know that you watched this is by submitting one of those Google forms. So those of you that attended the entire meeting today live, we really appreciate you being with us and taking the time here to learn a little bit more about what's going on in our area and what resources are available. So your attendance is counted by being here today. By filling out the Google form, if you watch this later, we can mark your attendance. And then if you are interested in purchasing clock hours through PD Enroller, that just requires registration of PD Enroller and filling out the survey at the very end. If you have any questions about PD Enroller, just go ahead and send me an email, and I'd be happy to walk through that with you. So I will be sending out an email to you following up with Ryan's contact information. So I just wanted to say thank you so much for being with us, and we really appreciate you and all that you do and your support for your schools and your students. And really quick, next month we will be having a presenter speak to us on 504 plans, and she has requested that you submit questions that she can address in her presentation. So please be sending me any questions that you have on 504 plans before the end of the month. So anyway, with that, we would like to thank you again for your time and turn you back into your work in the health rooms. Thank you so much, everyone.